It's really almost more for the whole institution. It's not only just for the chest pain observation area, it's also a manifestation of the emergency room from the cath lab, and incorporates a lot of different things. It's not only just for chest pain observation, but it's also for the management of acute myocardial infarctions or people who are clearly having MIs. So it's kind of reiterates the urgency that you need and the direction that you need to take care of people with a wide range of chest pains, which may be non-cardiac, but also may extend into people actually having heart attacks that we need to get to the cath lab and get the artery opened up and expedite their care as quickly as possible. We have incorporated over the past 4 or 5 years 12 lead EKGs in almost all of our outreach ambulances. So if someone is in a far area and they can get a 12 lead EKG, a lot of times there's a very accurate interpretation to that EKG, and they can go ahead and fax it in, and we can look at it, either the ER emergency room physician or even fax it to a cardiologist. And if someone is having a clear-cut myocardial infarction, it really helps expedite their care as far as getting them to the cath lab and getting the artery opened up. So it's improved outcomes, and it's particularly improved our mortality by being able to detect the myocardial infarctions early. So chest pain accreditation and our work doesn't just start in the hospital. It begins in an ambulance on the way here, or even in the helicopters that we have. And, you know, I'm very proud of what we've done with our acknowledgement of acute MIs. You know, once we recognize a myocardial infarction, we have the lowest facilitated times in the country as far as getting the artery opened up. And every 15 minutes, there is an incremental or a statistically significant setback of myocardial infarction of mortality. So our door to balloon times, from the time it's recognized, from the time they reach our emergency room, the national standards are 90 minutes, and we average almost 45 to 50 minutes. So we have cut what the country has demanded completely in half, and we lead the way in the entire country with our revascularization times for people having active heart attacks. We're very much able to lead the way with our protocols, and we've had several facilities, large facilities at other places, that's taken our guidance and taken the protocols that we've used and it's incorporated into their own programs. It's going to be difficult, I think, to challenge ourselves further from this 50-minute or 40-minute door to balloon time, but we'll keep raising that. We'll keep trying to push the envelope, and we'll keep pushing ourselves and see if we can continue to improve what we've already made great strides in.